Miss Odom, this is Kylie, and today I'm going to show you how to do an eye, ear, nose, mouth, throat, and breast examination on my patient Ethan. The first step we're going to do is to check his eyes. Usually you start doing this by performing a central visual acuity test. This test is performed by using the Snellen eye chart. This chart has lines of letters arranged in decreasing size. I'm not actually going to perform this test because I do not have the Snellen chart here at home, but I will walk you through the steps. The first step is to make sure that the chart is in a well-lit area. You're going to place your patient at exactly 20 feet from the chart. If the patient wears glasses or contacts, have them leave them in place. However, if they do wear reading glasses, they will need to remove those because sometimes the reading glasses will make the letters blur. You're going to begin by asking the patient to cover one eye or give them a card to cover their eyes that they can't see through. Then ask the patient to begin by reading the smallest line that they can read first. If they can read the next smallest line, have them do that until they are unable to read the next line. The result will be scored by using the numeric fraction at the end of the last successful read. If patients are not able to see the biggest numbers, shorten the distance to the chart until it is seen and record that distance. 20/20 is normal vision. The top number indicates the distance that the person is standing from the chart, and the bottom number is the distance at which a normal eye could have read that line. For example, 20/30 vision means that you can read at 20 feet what the normal eye can see at 30 feet. The larger the bottom number, the worse the vision. If acuity is poorer than 20/30, patients need to be referred to an optometrist. An alternative to the Snellen chart is to use a handheld vision screen that has various sizes of prints. This may be used for older patients or patients who have difficulty seeing or reading. With this test, make sure you hold the card 35 inches away in good lighting. Test each eye separately with the person wearing the glasses. Normal is 14 in each eye without hesitancy and without moving the card forward or backward. If the card is not available, then you may ask the patient to read print from a magazine. So the next test we are going to discuss assesses visual fields. First test is the confrontation test. And I'm going to ask Ethan to come and sit down so I can test his peripheral vision. I'm going to give him one of these cards so he cannot see through it. Okay. He's going to cover one of his eyes, and I'm going to cover the opposite eye of mine. Now I'm going to hold a finger midline between him and I and slowly advance it in front of the peripheral vision in several directions. He's going to tell me now when he sees the target, and there are 5 areas we're going to test. They are nasally, superiorly, temporally, inferiorly, and the anterior posterior axis. Okay, so hold this over one of your eyes. Yeah, I'm going to cover this eye. Okay, tell me when you see my eye. Look at this eye. Tell me when you see my finger.
I see it.
Okay. Now in this area. Here.
Okay, I see it.
Okay.
I see it.
Okay. Now
Okay.
okay, perfect. So abnormal results would be if Ethan were not able to see the object that I do. Usually this suggests peripheral vision loss. In older adults, this screens for glaucoma. So now I'm going to test the extraocular muscle function, and this includes testing the corneal light reflex. Okay. So Ethan, all I want you to do is just stare ahead of me, ahead at me. Good. And I saw the cornea light reflex shine from both of his pupils right in the middle. So if there was asymmetry of this, that would indicate deviation in alignment from the eye muscle weakness or paralysis. Now we're going to do a diagnostic positions test. This test will show any eye muscle weakness during movements. Okay, so you're going to look at me and you're going to follow my finger, okay? Good, perfect. This test will show any eye muscle weakness during movements. With normal muscle strength, both eyes should track the object, which they did. Nystagmus at an extreme lateral gaze is normal, but anywhere else it is not normal and warrants further investigation. So when I was assessing his cornea, I was also looking at his sclera, and I did not see a white line or a white rim between the lid and the iris, meaning there's no lid lag. So lid lag usually occurs with hyperthyroidism. And now I'm going to begin assessing the external ocular structures. I'll begin with the most external parts first. So as Ethan walked to the chair, I noticed that he was able to move around the room and avoid obstacles and respond to my directions. He didn't have to use his hands to grope to find his way, and there was no squinting or craning forward. So next we're going to look at the eyebrows, which they are present bilaterally. His facial movements are symmetrical, and there is no scaling or lesions present. If there were unequal or absent movement of his eyebrows, I would be concerned of nerve damage being present. Next, I'm going to look at his eyelashes and eyelids. His eyelids overlap the superior part of the iris and approximate completely with the lower lids when closed. The skin is intact without redness, swelling, discharge, or lesions. The eyelashes are distributed evenly along the lid margins and curve outward. There's no lid lag. No signs of incomplete close or use, ptosis, periorbital edema, or lesions. So now we're going to look at his eyeballs. They're aligned normally within the sockets. There's no signs of exophthalmos or inophthalmos. So now I'm going to assess the conjunctiva and sclera. So I'm going to have Ethan look up, and while he's looking up, I'm going to place my thumbs underneath his eyelids and slide the lower lids down. Okay. So just look straight first. Good. So his eyeballs are glossy and moist, the conjunctiva are clear, and spin over the lower lids and the white over the sclera. There's no color change, swelling, or lesions present. It's not tender, no foreign body present, and no discharge. Jaundice will present as a yellowing of the sclera that extends up to the cornea, or also called sclera icterus. So the next test we could do would be a version of the upper lid. However, I'm not going to perform this technique because it is typically not part of a normal eye exam. However, you would do this technique whenever the upper lid needs to be assessed as within suspicion of a foreign body or eye pain. So now I'm going to assess the lacrimal apparatus. I'm going to have Ethan look down and use my thumbs to slide the outer part of the upper lid along the bony orbit to expose the underlid. I'm looking for redness, swelling, okay, good. I don't see any redness or swelling. Now I'm going to check his lacrimal duct, or also known as the tear duct. I'm going to place my finger on the inside of the corner of his eye. Just going to push it forward. There were no abnormal findings, but if they were, they would include swelling, if the puncta was red or swollen, if it was tender to pressure, and if there is regurgitation of fluid out of the puncta, which would confirm duct blockage. So So now I'm going to assess the anterior eyeball structures, which include the cornea, lens, iris, and pupil. I'm going to begin by shining a light from the side across the cornea to check for smoothness and clarity. Okay, it was smooth and clear. There's no cloudiness in the cornea, the anterior chamber, or the lens. The iris is flat, round, regular shape, and even coloration. Now I'm going to check his pupils. Perfect. So his pupils are equal in size. They are round and regular in both eyes, and his pupil size was 4 millimeters. So next I'm going to check his pupillary light reflex. And I'm going to dim the lights to do that. Okay, so I'm going to have Ethan stare straight ahead. And I should see contraction of the same sided pupil as the other pupil constrict at the same time. Perfect, and they did. Okay, so now I'm going to test for accommodation. I'm going to ask Ethan to focus on my finger. Okay, look at my finger. Perfect, and his eyes accommodated well. So Ethan's pupils are what we call perla. Pupils are equal, round, reactive to light and accommodation. So now I'm going to darken the room again, and if Ethan were wearing glasses, I would have them remove them. And I'm going to have him look at an object ahead of him and look for his red reflex. Perfect. So there were no opaque areas noted, which is an indicator of cataracts. And I was able to see, not yet, just kidding. Perfect. So on that second assessment, I was able to see the optic disc, the retinal vessels, the background, and the macula. The optic disc was creamy yellow. It should be round or oval, and it was. The margins should be distinct and sharply demarcated. The physiological cup is a brighter yellow white than the rest of the disc. So no abnormal findings there. Abnormal findings include a scleral crescent, which is a gray white new moon shape that occurs when pigment is absent in the choroid layer. A pigment crescent is black and is caused by the accumulation of pigment in the choroid. So when I was assessing his retinal vessels, they were present. There were no arteries and veins crossing. The general background was light red without signs of lesions, and the macula was 1 dd in size and at 2 dd temporal to the disc. Pigment should not be clumped and may occur with aging, trauma, or retinal detachment. Foveal light reflex was present, and there was a tiny white glistening dot that was reflecting.